Bismillah ar-Rahman ar-Rahim. Urinary tract infections, UTI. Prevalence. The prevalence of UTI is 1 to 3% in girls and 1% in boys. In girls, the first UTI occurs by the age of 5 years, with peaks during infancy and toilet training. In boys, it's mostly during the first year of life. It is much more common in uncircumcised boys. The prevalence of UTI varies with age. During the first year of life, male to female ratio equal to 2.8 to 5.4 to 1. Beyond 1 to 2 years of life, male to female ratio equal to 1 to 10. Etiology. UTI is mainly caused by colonic bacteria. The most common bacteria in females is E. coli, representing 75% to 90%, followed by Klebsiella and Proteus. In males, some reports say that after the first year of life, Proteus equal to E. coli. Other reports reveals the preponderance of gram-positive bacteria. Staphylococcus, saprophyticus, and enterococci are a pathogen of both sexes. There may be viral causes of UTI, especially adenoviruses, which may cause cystitis. UTI have been considered as an important risk factor for the development of renal insufficiency or end-stage renal disease, but only 2% of current renal insufficiency report a history of UTI, which may be due to better recognition of the risk of UTI and prompt diagnosis and treatment. Furthermore, many children receive antibiotics for fever without a focus, resulting in partially treated UTI. Clinical manifestation and classification. There are 3 basic forms of UTI. 1. Pyelonephritis. It is characterized by any or all of the following symptoms: abdominal pain, flank pain, fever, rigor, malaise, nausea, vomiting, and occasionally diarrhea. Fever may be the only manifestation. Newborns can show nonspecific symptoms as jaundice, poor feeding, irritability, and weight loss. Pyelonephritis is the most common serious bacterial infections in infants less than 2 years of age who have fever without an obvious focus. Acute pyelonephritis can result in renal injury, which is called pyelonephritic scarring. Acute lobar nephronia or acute lobar nephritis is a renal mass caused by acute focal infection without liquefaction. It may be an early stage of renal abscess. Perinephric abscess can develop also. 2. Cystitis. Symptoms include dysuria, urgency, frequency, suprapubic pain, incontinence, and malodorous urine. It is usually without fever or renal injury. Acute hemorrhagic cystitis is often caused by E. coli and may be attributed to adenoviruses. 3. Asymptomatic bacteriuria. It is defined as a positive urine culture without symptoms and occur almost exclusively in females. This condition is benign and does not cause renal injury except in pregnant women, in whom, if untreated, it can lead to symptomatic UTI. Pathogenesis and pathology. Nearly all UTIs are ascending infections. The bacteria arise from the fecal flora, colonize the perineum, and enter the bladder via the urethra. In uncircumcised males, the bacteria arise from the flora beneath the prepuce. In some cases, the bacteria ascend to the kidney to cause pyelonephritis. In rare cases, renal infections may be occurring by hematogenous spread. Risk factor for UTI. These include female sex, uncircumcised male, vesico-ureteric reflux, toilet training. In female, UTI often occur at the onset of toilet training due to voiding dysfunction, which occurs at that age, leading to incomplete bladder emptying. Obstructive uropathy leading to hydronephrosis and urinary stasis, urethral instrumentation during voiding cystourethrogram or non-sterile catheterization, whooping from back to front, tight clothing, pinworm infestation, constipation, which may lead to voiding dysfunction, P. fimbriated bacteria. There are two types of pili or fimbria on the bacterial surface, 1 and 2. Type 2 fimbria, which is found on some strain of E. coli and can be agglutinated by P blood group RBCs, are more likely to cause pyonephritis. Anatomic abnormalities like labial adhesion, neuropathic bladder leading to incomplete bladder emptying, and the Troser sphincter dyssynergia. Sexual activity in female due to incomplete bladder emptying. Pregnancy is another risk factor leading to 4 to 7% have symptomatic bacteriuria. On the other hand, breastfeeding will decrease the incidence of UTI. Diagnosis of UTI. UTI may be suspected based on symptoms or finding on urinalysis, or both. A urine culture is necessary for confirmation and appropriate therapy. There are several ways to obtain a urine sample. Some are more accurate than others. In toilet-trained children, a midstream urine sample usually is satisfactory. The introitus should be cleaned before obtaining the specimen. In uncircumcised boys, the prepuce must be retracted. If the prepuce is not retractable, a void sample may be unreliable and contaminated skin flora. In children who are not toilet trained, a catheterized urine sample should be obtained. Alternatively, the application of an adhesive sealed, sterile collection bag after disinfection of the skin of the genitals can be useful only if the culture is negative or if a single uropathogen is identified. However, a positive culture can result from skin contamination, particularly in girls and in uncircumcised boys. If treatment is planned immediately after obtaining a urine culture, a bagged specimen should not be method because of a high rate of contamination, often with mixed organisms. A suprapubic aspirate generally is unnecessary. Prompt examination of the urine sample is important because if urine remains at room temperature more than 1 hour, this leads to overgrowth of a minor contaminant, so the sample should be stored in the refrigerator. The sample for general urine examination should be obtained from the same specimen as that culture. Pyuria, that is white feces in urine, suggests infection, but infections can occur without pyuria and vice versa. Sterile pyuria, which is positive leukocyte and negative culture, occurs in partially treated bacterial UTI, viral infection, renal tuberculosis, renal abscess, UTI in the presence of urinary obstruction, urethritis due to sexually transmitted infection, inflammation near the ureter or bladder like appendicitis, Crohn's disease, and interstitial nephritis. Nitrates and leukocytes esterase tests are usually positive in infected urine. Microscopic hematuria is common in acute cystitis. White feces cast in the urinary sediments suggests renal involvement, but these are rare. With acute renal infection, there may be leukocytosis, neutrophilia, necrosis, and C-reactive protein. With renal abscess, the white feces count may be more than 20,000 to 25,000 per cubic millimeter. Blood culture is indicated with suspicion of sepsis, which is commonly seen in pyonephritis, especially in infants and in child with obstructive uropathy. If the child is asymptomatic and general urine examination is normal, so UTI is unlikely. If the child is symptomatic and general urine examination is normal, UTI is likely. If the culture shows more than 100,000 colonies of a single pathogen, or if there are 10,000 colonies and the child is symptomatic, the child is considered to have a UTI. In a bag sample, if the urinalysis result is positive, the patient is symptomatic, and there is a single organism cultured with a colony count more than 100,000, there is presumed UTI. If any of these criteria are not met, confirmation of infection with a catheterized sample is recommended. Treatment of UTI. Treatment of cystitis. The choice of the suitable antibacterial drug should ideally be based on the result of urine culture and sensitivity. However, in acute severe condition, treatment should begin without waiting for results. That is empirical therapy. The course is that of 3 to 5 days or sometimes 7 to 10 days of one of the following oral antibiotics. First, trimethoprim sulfamethoxazole, 4 to 6 mg trimethoprim per kg per day divided into 2 doses. Second, nitrofurantoin, 5 to 7 mg per kg per day in 3 to 4 divided doses. Should not be used with the febrile UTI because it does not achieve significant renal tissue level. Third antibiotic is amoxicillin, 50 mg per kg per day in 2 to 3 divided doses. Treatment of acute pyonephritis. The course is that of 14 days of one of the following parenteral antibiotics. Ceftriaxone, 50 to 75 mg per kg per day, not more than 2 grams per day. Ampicillin, 100 mg per kg per day, plus gentamicin, 3 to 5 mg per kg per day in 1 to 3 divided doses. Side effects of gentamicin include ototoxicity and nephrotoxicity. Serum creatinine and gentamicin level must be obtained before treatment, then daily assessment should be done. Aminoglycosides are particularly effective against Pseudomonas, and alkalization of urine with sodium bicarb lead to increase their effectiveness in the urinary tract. Other oral antibiotics include one of the following: oral third generation cephalosporin as cefixime, 8 mg per kg per day in 1 to 2 divided doses. This drug may be the drug of choice of oral treatment. It is not effective against Pseudomonas. Oral ciprofloxacin, 15 to 30 mg per kg per day in 2 divided doses, is an alternative drug for resistant organisms, especially Pseudomonas, in patients more than 17 years and in patients less than 17 years of age with cystic fibrosis, pulmonary infections secondary to Pseudomonas, and occasionally for children with Pseudomonas UTI. Side effects of ciprofloxacin include potential cartilage damage in children. So this leads to restricted use in pediatric age group. Sometimes with febrile UTI, a loading dose of IM ceftriaxone followed by oral third generation cephalosporin is effective. Renal or perirenal abscess or infections with obstructive uropathy need surgical or percutaneous drainage plus antibiotics plus other supportive treatment. Note: first, urine culture and sensitivity should be performed 1 week after the termination of treatment of any UTI. Second, follow-up urine culture should be performed periodically for 1 to 2 years, even with asymptomatic child. Supportive therapy include increased fluid intake, antipyretics as paracetamol, 10 mg per kg per dose 4 to 6 times per day, or ibuprofen, 10 to 15 mg per kg per dose 3 to 4 times per day. Bladder analgesics may be used in older children to relieve pain associated with severe dysuria as phenoxypyridine, Uricept tab, 10 mg per kg per day in 3 divided doses. Alkalinizing agent as sodium bicarb or sodium citrate are especially useful with aminoglycosides. The dose is 1 teaspoon of granule plus some water 2 times per day. Long-term antibiotic prophylaxis. It is the prophylaxis against reinfection using either trimethoprim, sulfamethoxazole, or nitrofurantoin at 1/3 of the therapeutic dose once a day, which is often effective. Prophylaxis with amoxicillin or cephalexin may be inappropriate because of the rapid development of bacterial resistance. A 6 to 12 months course is indicated. If infection recurs after stopping prophylaxis, antibiotics should be resumed. Indication for antibiotics prophylaxis are: first, infant or children with their first UTI who have finished their course of treatment and waiting for completion of other studies as voiding cystoarthrogram or renal ultrasound. Second, patient with non-urologic abnormalities which place them at high risk of recurrent UTI as neurogenic bladder, urinary tract stasis and obstruction, vesico-urethral reflux, calculi and posterior urethral valve. Third indication include children and adolescents with recurrent UTI and normal urinary tract anatomy. Treatment of consequences of chronic renal damage caused by pyelonephritis as hypertension and renal insufficiency. Another important subject is imaging study. The goal of imaging studies in children with UTI is to identify the anatomic abnormalities which predispose to infection. First, renal ultrasound should be obtained to rule out hydronephrosis, renal or perirenal abscess, acute pyelonephritis in 30 to 60% of cases by demonstrating enlarged kidneys, which may require prompt drainage of the collecting system by percutaneous nephrostomy. Normally, the differences in renal length of two kidneys is less than 1 centimeter, and large disparity may lead to impaired renal growth. Renal ultrasound can be done with other studies or at time of hospital admission if the patient appears toxic or hypertensive or if there is evidence of decreased renal function. Second investigation is voiding cystoarthrogram. It is indicated in the following conditions: all children less than 5 years of age, any child with febrile UTI, school-age girls with more than one attack of UTI, any males with UTI. The most common finding is vesico-urethric reflux, which is identified in about 40% of cases. Timing of voiding cystoarthrogram is controversial. In some centers, the study is delayed for 2 to 6 weeks to follow the inflammation to heal. However, the incidence of VUR is identical irrespective of whether the voiding cystoarthrogram obtained during treatment or after 6 weeks. So obtaining voiding cystoarthrogram before discharging from the hospital is recommended. Other investigation is technetium labeled dimercaptosuccinic acid or glucohyptonate. It is useful when the diagnosis of acute pyelonephritis is uncertain. If vesico-urethric reflux is present, the DEMSA scan often is performed to assess whether renal scarring is present. The DEMSA scan is the most sensitive and accurate study for demonstrating scarring. Other investigation is excretory urography. It is not as sensitive as that for DEMSA scan in demonstrating renal scarring. In addition, the visualization of the collecting system in infants and young children often is suboptimal. There is high risk of contrast allergy and it can take 1 to 2 years for renal scar to appear in urogram. The last investigation is computed tomography. It may demonstrate acute pyelonephritis and renal scarring. شكرا جزيلا لحسن إصغائكم.